This episode is brought to you by IndieBase, the smart, simple and budget-friendly electronic patient report system built for the realities of HEMS work and pre-hospital care. Whether you're a solo responder, part of a flexible team or working across a large organisation, IndieBase is the right solution for you. So it works on any device, laptop, tablet or smartphone, and crucially it runs offline when you need it the most. So born from trusted foundation of HEMSbase and built by the Medic One systems team, IndieBase combines a familiar intuitive interface with rock solid reliability. So from festival first aid to complex patient transport to high acuity critical care, IndieBase is ready for every pre-hospital scenario. So it integrates with all popular pre-hospital monitors and includes powerful case review and indeed clinical governance modules. So it's ideal for maintaining high standards and supporting services preparing for CQC registration. So there's also a dedicated patient feedback module, which when used alongside clinical governance supports continuous improvement and patient-centered care. So for those working across multiple organizations, IndieBase gives you a personal logbook that unifies your data and even integrates with your HEMS-based logbook. So it's quick to deploy, easy to use and built for the field. IndieBase makes electronic patient reporting simple wherever you are. So find out more at indiebase.net. That's INDIEBASE.net or head to the show notes for further information.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're joined again by Mike Palmer, critical care paramedic, to talk about ultrasound. In today's conversation, we're going to talk about the practice of ultrasound, but also the governance and indeed lessons learned from Mike's own practice with ultrasound. So we're going to dig into the practicalities of training, including insights around having a HEMS hybrid ultrasound program, and indeed the realities really of translating core emergency ultrasound qualifications into real world pre-hospital context. So we're going to look at image recognition in simulation, but also looking at the utility of logbooks and indeed internal image review or governance. And Mike's really going to share how services navigate the training and governance aspects of ultrasound that come along with deploying this diagnostic tool out of hospital. We're also going to tackle some of the real world hurdles that of really getting useful images in stressful critical care environments, to managing the risks of false positives and or misdiagnosis. We're also going to look at using ultrasound findings to influence decisions about triage and treatment. And finally, we're going to just really hear personally from Mike around the lessons learned from his years of practice with ultrasound in pre-hospital care. Welcome to the podcast, Mike.
Hi, Owen. Thanks. Great to be here.
I wondered if we just start, mate, by getting really you to speak on how you got first involved with ultrasound in practice and indeed how it was embedded within your service.
Yeah, so I've been really lucky now that I've been on HEMS or enhanced care teams for 5 years. And when I started back in 2020, I was with London's Air Ambulance, and yeah, they were carrying an ultrasound device. But it'll be right for me to say that the majority of the time it was getting out the bag, it was for their endovascular techniques, so the rubber and getting those sheaths in. I know they did have there was an ultrasound scan before regarding with chest, but they didn't have like a formal kind of SOP that what they've got now today. So during that period in 2020, I know you say whether it was luck or do you make your own luck really, but Dan Nevin and his colleagues were kind of had the goal of kind of bringing a full-fledged ultrasound device with 3 different probes into the service, and then when we had the 3 probes, got the ultrasound devices and the building up that kind of governance structure and the SOP. And I kind of grabbed the bull with kind of 2 horns really, and shout out to Dan Nevin. He kind of took me under his wing really, and kind of got involved that way, realizing a massive gap in my own practice, feeling a bit vulnerable really, if I'm honest, and I feel that I kind of wanted to kind of learn and get good at something which I kind of wanted to become an apprentice to a bit of I wouldn't call myself a master just yet maybe, but no, far from it. But I wanted to kind of really get involved, and I think just that passion there kind of drove me first and kind of got involved, and I just even to the early days, I remember kind of like scanning patients and And at the time, with the difficulties of uploading and sending them to my NHS Net account and things, and trying to make a logbook was difficult, really. But that's how it's kind of really kind of developed my kind of journey, really. And then fantastic time down at LAA, kind of again fortunate then to kind of move on to another service. And again, they were at the infancy with their kind of ultrasounds. They did have it, but the governance is not quite there. They were getting a new ultrasound device as well. So again, it's trying to like kind of build everything all together. It's still a journey, but enjoying the ride.
Yeah, indeed, indeed. Let's just look at just jump into what a HEMS hybrid training program would look like from your perspective, or indeed from your experience, Mike. And how does it prepare clinicians for real world ultrasound use in the field? Could I get you to speak to maybe reflections on what you've experienced about a hybrid program?
I think you need to look at the service, the makeup, the crew resourcing as well. Whether you're like a solo paramedic, critical care paramedic, a double CCP, or a doctor and a paramedic as well. And how long are those secondments, for example? Are you part-time, full-time? Are you only there for a period of time as well? And this is what I kind of originally learned from LAA. And I'll put we'll put the paper on the show notes, really. But there was there's the hybrid model, really, with LAA, for example. We know that paramedics are quite junior in their field, especially with critical care initially, and then you might have a physician with them who are there for 6 months. The paramedics are primarily there normally for 12 months. And how do you, financially, do you put them all on ultrasound courses? Do you put them on a 2-day course? Time, money, etc. Fantastic doctors and paramedics, but they might be from all around the world, from different, primarily it's normally from anesthetics or EM backgrounds, but they might be familiar with one part of echo, but not what they use it for example. So they had this hybrid model, for example. Listeners can read their paper themselves, but they kind of concluded that it increases confidence, image interpretation, from even like a 2-day course that they did, and with the ongoing learning. But I feel what was really difficult then is like if you've got that there, how do you kind of replicate a certain model to a different HEMS service or a different enhanced care team or a paramedic led team, really? So I think it's an individual service basis, but then it's what's the right word, really? I think it's making sure that you are competent, and then you've got somebody there that you can review the scans as well.
Yeah, exactly. So there's actual competence and feedback from review of scans, and I think there's probably as much learning from feedback as there is about real time scanning. Could I get you to? I'm going to press you slightly and ask you about sort of certainly within a UK context, the core sort of level 1 emergency ultrasound course, or indeed some of the sort of foundation training that maybe medicine works with from the Royal College of Emergency Medicine. Could I get you to speak to sort of whether that is, fundamentally adaptable to post-world clinicians? Is there utility there? Is it something that maybe all services should be looking all critical care services should be looking as a baseline of competence?
Yeah, I feel like there's lots of level 1 ultrasound courses out there now. Even some HEMS services are providing them as well. And I feel like if you're a complete novice, they're definitely worth going on. It's you fundamentally learn the basics of ultrasound from the ground up. And I think that what you kind of learn from them is fantastic, but you need to be aware that you can't do a 2-day course and the way you go, because you'll suddenly go to a patient and it's a bit difficult. They've got different body habitats, a larger BMI, for example, and you'll really struggle to find an image. And then if you do find an image, you're not really quite sure what you're really kind of looking at. And I feel that what I've kind of learned really along my journey is that kind of scanning normal pathology. and normal kind of patients who you've got that time to to do that, but then also you can, when you've got that confidence of picking up a probe, decide on what probe to use, the setting, the gain, the depth, etc., and then really finding, okay, that is normal, or okay, though, and actually no, I'm really confident there that that is abnormal. So yeah, I would always encourage anyone, to do an ultrasound course, but be aware that some of them, especially the one that I did, fantastic course, but that was led primarily by in hospital clinicians. So what I kind of wanted to going forwards, realize that there was things that I needed to kind of learn and adapt. For example, if you're in the back of an ambulance and there's somebody on a scoop, for example, trying to get a view of the left upper quadrant is really, really hard. Um, did they tell me on my ultrasound level one course? No, they definitely didn't. So yeah, it's I feel like, and this is where we've come from my service now, is what we can we adopt from certain courses, bring them, and then have them, in our kind of bespoke course that we do for a 2-day course here in Wales.
So let's look at really some of the clinical application and decision making, Mike. Could you just walk us through point of care ultrasound, inpatient consultation, particularly under time pressure? We spoke on the last podcast about, there is a sliding scale of, do you need to start moving now? Is the patient pale, sweaty, with, apparent pathology that you need to move with now, versus the patient you have some more time with, they might, pain might be the overriding need or demand, that actually you need to really drill into a very difficult cannula, which actually you might need to rely on ultrasound for to find a vein. But could I get you to speak to where and when you determine to get the probe out under pressure, and indeed how you use it to guide other people through? Because one of the things I realized was there was kind of sometimes very much a teachable moment looking at point of care ultrasound from certainly a handheld device, where you could kind of bring the crew along with you, and you could almost guide them through the pathology and say, look, this is what I'm seeing. These are some of the image resolutions, but this is some of the underlying pathology I'm looking at, right? I'm looking for right now. And actually bringing the wider team, certainly the wider ambulance team, along with you on that journey.
No, it's a definite good point there, Owen, because I often think to myself when I'm kind of explaining ultrasound findings, or even that I've kind of, we technically save an image, and then when we do our clear up after the handover, I can often kind of go through with the crew about what I was doing if I didn't have time at the time to kind of explain to them. And that's a really good like teaching aid then as well. And I kind of think to myself, God, I'm quite jealous of you, because when I was a couple of years post registration, I didn't have this kind of like depth of ultrasound knowledge, and now crews are kind of explaining to me, oh yeah, that's that, or that's that, or that's the free fluid, that's the left ventricle, and I'm like, God, yeah, I didn't know this. That's epic. You kind of know this. So I think going back to the question, you need to, it's the whole, you don't do a primary and secondary survey and you just do an ultrasound scan. If you're in a dual team, it's quite nice that I know you do this, the primary and secondary survey, and then your other colleague will follow up scanning as well. And so I feel like it's that the broad brush stroke of, yeah, it's primary secondary survey and incorporate as well. And I think that's probably best. And as I said before, yeah, not use it as a standalone tool.
So just looking at just how ultrasound influences decision making on scene, certainly within your context, you do have quite a long way to travel, certainly to hospital, and certainly it might be the differentiator between a major trauma center or a local center. How much does the ultrasound inform your practice?
I think, yeah, well, yeah. So it informs, I think, or confirms decisions. I think, yeah, that's probably a better way to say it, really, because I think you can be in a bit of a sticky wicket sometimes if you can't solely rely on a scan and then make decision of like, oh no, they're completely fine and they've got no free fluid in their belly. Let's send them to a trauma center. And then all of a sudden we find out 2 hours later that they're having a secondary transfer. I think sometimes if you're maybe sitting on a fence, whether using a major trauma tool, if that we use, the observations are all completely fine, and you're thinking, okay, if I didn't have an ultrasound machine in my bag, I'll probably send in quite rightly with what's been given to you to a trauma center. But then, you scan somebody and they've got free fluid, for example. That's going to sway you, right? Okay, no, let's go to the major trauma center. So that would definitely kind of sway me, to go to a major trauma. More of a decision to kind of rule up more than a rule down, because you need to be very aware that you can miss stuff. And as we said before, serial ultrasound scans and scanning is really important as well.
So just looking at a key attribute really of scanning would be maybe the protocol that you prescribe to Mike. Dan Neville's been on the podcast, talked about the rush protocol, rapid ultrasound in shock and hypertension, and how he approaches that, and what he scans for first. There's the EFAS protocol, extended
Mm.
focused ultrasound for sonography and trauma. Just which protocol do you prescribe to, and or do you, and
Mm.
how does that how does that look in practice?
Yeah, so no, I definitely respect Dan's protocol. As we've said before about the three P's, isn't it? Pump, pleurin, and pour in bloods. But I definitely probably would, it's maybe because I've got a lot more time on transfer sometimes, or I do like to kind of finish the ultrasound scan as well. So I kind of do scan, the left upper quadrant, spinal, renal kind of views, suprapubic views as well, looking down towards the bladder. So I do kind of finish, that, typically what I kind of originally learn of just scanning just the right upper quadrant. So I think you need to be thinking about what do you think is going on with your patient? What's the pathology that you think? And that's going back to when you're first in paramedic school, isn't it? That we need to be taught, okay, what's going on here? Look at the mechanism of injury, look at the car crash, look at the engine block, out the vehicle. Okay, what's going on? Did they have a seatbelt on? Have they been ejected? Whatever. But then, are you expected to find something? Okay, so let's look for that. And then I think that will kind of helps guide the decision. So yeah, I think I take a very kind of proactive but dynamic kind of view and decision on that.
So, Mike, how do you approach balancing between avoiding false positives and ensuring you don't miss critical findings?
Mm, good question. I feel that not to kind of repeat myself, but that making sure that you have that serial scanning, even if you're not really confident or confident as well, having your colleague to scan as well. That could be another tool, or even say that, I'm not too sure, it's inconclusive. And I've definitely been in that situation as well, because I'm scratching my head. I'm thinking, oh, whether this is right or not, are we going to make this decision? And this is the thing, whether you're trying to make a decision on what you're finding, what's the consequences of that outcome? And if the consequences is sending somebody to the wrong hospital, or whether you do or don't give somebody a blood transfusion, it's making sure that you want to make sure you make that right decision, but understanding what you're seeing really as well. And this is going back to making sure that how many people you do scan, you want to look at what normal pathology looks like.
So, just looking at, and this is kind of a big question in a way, but what good governance looks like within principal ultrasound programs, particularly around accreditation, image review, supervision. Could I get you to speak? We could do a whole podcast just on that question, but
Mhm.
could I get you to speak to maybe indeed what you do, just your service, and how your service interacts with image review, accreditation, and supervision?
I think Dan won't mind me saying that they've reviewed thousands now of ultrasound scans, which is pretty amazing what the work we're doing there at LAA. And I think just to kind of revisit that, they have you perform an ultrasound scan, then you upload that to a drive, and then you write on a little kind of system where you basically say why you scanned and what you thought you saw, and then that will go to a reviewer, and we'll look at the ultrasound scans, in the cold, in the nice warm environment with a, flat white, and think, okay, really kind of look, okay, do I agree with that? Or even sometimes they even say, well, they'll look at the scan before what they thought they saw as well. And then you get that honest feedback of, what, the governance, yeah, yes, I agree, or don't agree. And then to another layer, Dan calls this the, the governance onion kind of layer. Really, there's another one that basically the reviews the reviewers, which is another kind of level, which is yeah, it's quite exceptional, really. And then we've been in with Wales, we've been in discussions with Dan about this as well, and how we can do this. And I think what starts off with is technology. I think that's, and what I'm kind of really kind of love with, I'm very fortunate with here in Wales, is that I can scan somebody and then convey to hospital. I'm doing my EPCR on the computer, and I click search, and then an ultrasound scan is already on the computer. And that then, even before I've done all my printouts, the ultrasound scan is uploaded and it's on the system already. And that, I think that's what's fundamental then about the building blocks then of governance. Well, then we have, the top cover reviews the call and the mission, and then you can look then, and then people can go into it and review the scan and build that governance up. So if you don't have that governance there, or it's, before we've all kind of downloaded onto a pen drive or sent it over to like, NHS email accounts and things, and it can be really clunky. And if the system's clunky, the governance can be clunky. It follows up as well. So yeah, to start off with that, I think you need to have that system, and I'm really fortunate to have that here in Wales. And then to go on with accreditation, one of the doctors that's kind of was leading it here in Wales is that, knows how keen I am doing my scanning and trying to build up a logbook, and he probably equated that, it'll take me over a year to have proper supervision and to be accredited, with other professional bodies. And it makes it tricky, even with training hours, with your other parts of your job that you need to keep up with as well. So we've kind of started this kind of like, a 2-day course, which follows the RChem guidance, but then it kind of brings the different aspects of what we already spoke about. We've got somebody on the floor with a Lucas on, how to manage that. We've got people on scoops. You've got people in bathrooms or whatever. It's like you need to kind of adapt to what you're training for. And if you don't do that, yeah, it's great to go into your level 1 course in a nice warm hospital environment on a nice bed at the right height, but it's not practical, because it's not what we do. And that's what we've really realized, really, is that what can we adapt from these other agencies and accreditation to have a well-governed system as well.
Yeah, listen, I think that's super relevant actually, because it's, to your point, it's about applicability and having that cross training which actually prepares you for practice, rather than some adjunctive training which actually is not necessarily as relevant to what you're seeing day to day. And so I firmly agree with that, Mike. Just looking at practical tips you've learned, like using standby mode, or indeed prioritizing positive findings for handover, aspects that make a real difference, or just even just the critical mass of scanning. I would try and scan more patients than maybe I needed to, because what I appreciated over time is that sometimes it's that kinesthetic feel of the probe on a patient, because no two bodies are the same, no two scans are the same, and almost there is a generic area of organs you're going to see, but actually there's variation, and it's only until you've got a critical mass of experience amongst that variation that you actually can quite quickly navigate the probe to where it needs to be. And got to get you to speak to some of the practical tips you've learned.
Yeah, no, we definitely in the infancy with having the new ultrasound devices at London's Air Ambulance. We went through that period of making sure that yes, they were on standby modes. We've very fortunate that they had lots of machines, so we could swap them in and out at the start of every shift. A lot of ultrasound companies will say that they've got a good battery life, and they do. You can be left on standby modes and left for a 12-hour period. And we do that, and it's absolutely fine. It doesn't drain the battery whatsoever with the the probe that we have. So that's definitely yes, 100%. And non-negotiable really is having that on standby mode, because even turn them on, all of a sudden what software like it gives you an update, and it's frustrating, and then you open up the bag and then you're basically shoving it back in the bag. So it's definitely a key point there, is having it there on standby mode. But yeah, and just being aware that you've got the gel ready in the same pouch, you've got all the sundries, you've got all the probe, whether you just have two probes or one probe or three, you've got them all there ready to go really. I normally typically have it at the top of one of my particular bags where we keep it, so it's easier grabbed than lower down as well. So these practical aspects is definitely is there. And I think yeah, maybe being aware of the typical standard stuff really of lighting. We can't do it in broad daylight. It might have to wait till you're in the back of the ambulance, because it's a nice sunny day, and you've got no chance of seeing anything meaningful which you're going to make a decision on. So definitely being aware of that as well. And yeah, going on, what I've learned really is that aspect of handing over those, yeah, either positive or negative. We've got a bit of a thing really of that. If you hand over a negative scan, it might lead the trauma team down a false sense of like security really. And we don't want to think, oh, okay, it's absolutely completely negative, and then the HEMS team said it was negative, so it's going to be still negative now. And that can be worrying really, and we try, yeah, not to do that, or don't do that really. Is, yeah, we only hand over those positive scans to have that informative handover as well.
So just looking as we're coming to land, actually, Mike, on the conversation, just a couple of things. One would be just how we can foster a culture of continuous ultrasound improvement from your thoughts, really, and indeed, especially when image quality might be poor, or indeed training opportunities are limited. What are some of the 1% we can really initiate to improve that culture of continual learning with ultrasound?
Yeah, I think what I say is definitely to some of my colleagues is that don't be afraid to get it out of the bag really. And if the time is right, we have got some time sometimes to do this. And if you're thinking, oh no, I'm not very good at it, or I'm not that confident, well, you definitely won't be confident if you don't get it out of the bag. So I definitely, I would say to encourage scanning. It's especially when the time is right, when you've got that period of time where you've on the way to hospital, you definitely can put your seatbelt on, put the probe on a right upper quadrant as well. You can definitely do that. And so why not really? I don't feel and when people say, oh, it's not going to change your practice, let's keep it in your bag. Well, that's great, but like maybe, I hate the word practice really, because we shouldn't be doing that. But like, what I do feel it does help the next patient when you've really made it feel comfortable scanning patients. And I know then it's because I've scanned so many people with normal pathology, I know that I'm really confident when the day comes when I really need to scan and it's all a bit heightened on scene. I've got that confidence there. So I would just say to encourage it really, if I'm honest, and because you're not going to get any better if you don't do it.
So just finally, Mike, just if you could, your journey has been prolific within ultrasound, because like you said before, the adoption, you came into some of the teams at a really special time when adoption was key, and how do we embed this and through the longevity of time as well, so we keep getting better, improving, and being consistent with this. But could I get you to speak to some key lessons you've learned, both maybe technically and or culturally, that you pass on to others? A scheme that's maybe starting out and it's looking to embed a hybrid ultrasound course, or indeed a system and a governance system, and just what are some of the key attributes that you would advocate?
Yeah, I think I don't know. Just to set up a point on that is that I'm always happy for people to reach out and get in contact. Really, so yeah, please do. But yeah, I feel that you just need to have this the understanding that you want to make sure you're quite hungry for it, really. And I think that's where I kind of initially kind of happened with me, is that I was just so yeah keen to learn, and that's kind of like just kind of like snowballed, and it's kind of brought either more opportunities that came my way. And I just feel that, don't worry about reading that textbook. YouTube, fantastic resource. I'm still learning all the time, really, with aspects. And people often say that a lot of people are self-taught, aren't they? Be ultrasonographers, especially if you don't go through official routes. But then I feel like I remember, like, scanning your crewmates, your pilots. It's a really nice tool. Even when I've got students as well, I can spend a time teaching them, because they can see it. They can scan themselves, or whatever as well. And you have fantastic models now these days. So it's something really practical you can do while on shift and on base, if you've got that time, or very fortunate to have that time as well. And then, especially when you go on a particular ultrasound courses as well, having actual patients come in with triple A's, and then you're trying to find that as well, that they're really kind of fortunate, kind of offering their time to some courses. So I think just the journey is just, it comes within, I think, really. I think to answer the question, and I think you never know where the journey might go with it all. And for me, it's just, enjoying it all.
Yeah, fantastic, mate. That's fantastic. And to your point around just the governance onion, as you were saying, and as Dan never advocates, is super powerful, because what it does is it starts to give feedback to the reviewers, and feedback to the whole system, whereby you can start to get some really interesting feedback, but also start to refine process, and also start to refine interpretation, and all that feedback is helpful, super helpful. So it's fantastic to see that happening and proliferating into Wales and other places as well. Absolutely. Listen, thank you for your time. It's really nice just to touch base with you, Mike, and just get some of your received wisdom on this. So thank you.
Thanks. Yeah, no, it's been great doing, and hopefully another time.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.